Good afternoon, everyone, and welcome to the 2020 VHHA Lunch and Learn webinar series. This webinar series will focus on quality, patient safety, and high reliability in healthcare facilities around Virginia. My name is Christy Burnett, and I'm the Director of Patient Safety and Quality in the VHHA Center for Healthcare Excellence. I'm your moderator for today's presentation. Before we get started, there's a few housekeeping items I want to share with you. Please know that this webinar is being recorded. All participants are muted. Questions and comments will be addressed at the end of the presentation, but feel free to enter them at any time in the question box. There'll be a short feedback survey that will launch at the completion of the webinar, and this series does require only a one-time registration. Now I'd like to take the opportunity to introduce our presenters. Today with us we have Diana Willman, the Director of Pharmacy Services, and Katie Stokes, the Medication History Tech at Southside Regional Medical Center. Diana graduated from VCU School of Pharmacy and completed her PGY-1 residency at Centera Healthcare before joining Southside Regional as a clinical pharmacy manager in 2008. She's been the Director of Pharmacy at Southside since 2012. Her areas of interest include medication error evaluation and process improvement, medication safety, and drug diversion. Katie has been a certified pharmacy technician since 2010. Prior to joining Southside Regional as a medication history technician, Katie's background was oncology pharmacy, including sterile compounding of hazardous medications. She became interested in MedRec when she noticed patients' medication lists were not being updated when they came to the oncologist's office. She enjoys patient contact and the ability to help patients stay as healthy as possible. Welcome to Diana and Katie, and the floor is now yours.
Good afternoon, everyone, and thank you so much for the opportunity to present our medication history program with you this afternoon. Just want to tell you a little bit about Southside Regional. We are a 300 licensed bed facility. That's on the next slide, Christy, I'm sorry. 300 licensed beds. We have over 1,400 associates, and we have over 490 providers. We have a multitude of service lines, and we serve the Tri-Cities area. In particular, I wanted to mention that we have a level 3 trauma center, and we have approximately 67,000 ED visits a year. Next slide, please. And this is just a few highlights of our service line accreditations here at Southside Regional. Next slide, Christy. Okay, and so we'll just do a little overview of the objectives that we'll cover today. Initially, we're going to discuss the implementation of our ED, Medication History Technician program. We'll also cover some elements that the Med History Tech performs, and we'll describe some improvements that we have seen in the accuracy of med history at our facility, as well as some process improvements that we were able to make. And then we'll just cover some future applications for this role, at least at our facility. Next slide. Just to give you a little bit of background, anyone that's worked with medication reconciliation, med histories, knows that this is a very challenging process. At our facility, the med histories have primarily been collected by the nurse, and when the patient presents in the ED, that task falls upon the ED nurse, who is being pulled in a multitude of different directions. It is a very time-consuming process to perform med histories correctly and to form it in depth and get the necessary clarifications and corrections needed. When there are inaccuracies in the med history, it can lead to many different sequelae, including delays in patient care. Patients can feel a reduced sense of satisfaction as they feel that we don't know what medications they are taking. They lose confidence in our ability to manage their meds. It causes additional time from pharmacists to nurses and physicians to clarify orders. It can increase a patient's length of stay if their medication history is not correct. And worst of all, it can cause patient harm if there's an omission of something critical, particularly an anticoagulant, a seizure medication. And when we started looking at medication histories at our facility, we were very concerned to find that we had about a 43% unintentional discrepancy rate at our facility using our Leapfrog data. So that literally means out of every 100 orders, 43 of them had something wrong, whether it was the dose, the frequency, perhaps the wrong med was listed, or maybe it was even an outdated medication the patient was no longer taking. We developed a task force that reported to our P&T, and it contained members from administration, quality, clinical informatics, nursing, pharmacy, and we even added several of our physician leaders who were high volume admitters or our hospitalists, and we wanted to tackle this issue. We had a brief pilot of med history technician in the ED in 2018, and that was favorable. Next slide, please. So the medication history technician vision that we had at our facility, and mind you, this is not unique to our facility, and this is not a new concept. Many facilities have implemented this probably years before, but this was something that we were excited to bring to our facility. We wanted to obtain the best possible medication history in a cost-effective manner, and we wanted to focus on the accuracy of med histories at admission. Certainly there's opportunities throughout the entire process, but we felt that if we could get admission medication histories correct, that would benefit the patient throughout the hospital stay, including discharge. The qualifications we envisioned for our med history tech would be a certified pharmacy tech with excellent intrapersonal skills. And as you saw, Katie has an oncology background. She was not a retail technician. She had not been familiar with some of these medications, and we selected Katie because she was actually the best fit in terms of her interpersonal skills, and we knew that we would be able to train her on the actual medication history piece. As far as the goals, we wanted to increase the efficiency of our ED admissions throughput, as well as the efficiency regarding time spent on clarification of these orders. We wanted to reduce the number of incomplete orders that were coming to pharmacy, as our prescribers were able to sign off on orders that were missing doses, missing frequencies. We wanted to reduce that number of incomplete orders and also the discrepancy rate between what the patient's actually taking and what got listed and ordered. And then we wanted to prevent error recurrence by getting the medications updated in the EMR so that the errors that we were seeing were not perpetuated. On the next slide, we demonstrate that in February 2019, we were able to implement a med history technician at our facility. We decided on a coverage of Monday through Friday, 10 to 6:30, to try to cover some of the later afternoon admissions. We also decided this would be a budget of 1 FTE coming out of the pharmacy. Some facilities do ascribe this technician to the ED budget. Sometimes it's split between ED and pharmacy, but in our case, our productivity was able to support that technician coming out of the pharmacy budget. The tech was located in the ED, and the contact would either be physician or nurse approaching Katie directly or using a secure messaging system to reach her. We quickly realized that she would need a workstation. She would also need access to the ED tracking board. That was very important in terms of determining where the patient was in the admission process, and then some drug info references. And we even provided things such as our own internal, insulin product charts and things like that to help Katie with her data collection and make sure her lists were accurate on her patients. The primary interfaces for Katie would be the ED nurses. Hospitalists always utilize her skill set, as well as the patient, of course, and then at the end of all of her patient lists, she turns those into our lead pharmacist who helps provide oversight into the accuracy of her data collection. And now I'm going to turn it over to Katie, and she's going to tell you more about her process firsthand.
Hello, I'm Katie, and whenever I get approached by a physician or a nurse in the ED, they usually come to me with the patient name or room number, and then I sit down at the computer in our EMR and I go ahead and get everything ready before I go into the patient's actual room. Whenever I go to get everything ready, in our EMR, we can pull an external history that will show us what the patient has filled recently from the local pharmacies, as long as they use their insurance card or they are at a facility. It would show a a mail order pharmacy. Whenever I pull all of that, I will go through and make sure that the dates and the quantities match up. For example, if it was an antibiotic about a month ago, I would just ask the patient if they had completed that antibiotic. Whenever I go in and talk to them, sometimes the patients are not alert enough. So if they have a medication list, or if they have a MAR from a facility that they are from, or even a family member, that's how I will interview and try to collect all of my data first. I will go down the list and compare what they have with them to what the external history shows. And if anything is out of the ordinary, say the date doesn't match up on the bottle, or the quantity doesn't match up with what I see, I will flag that and do my research on that outside of the room. If the patient's not alert, there's other ways that I can try to figure out where they are filling stuff from, as I would look at the PMP and see if they've had any narcotics recently filled. That will actually show what pharmacy they use. So if I cannot see any of that information, at least I can call the pharmacy. I've even also have looked at their address and called all the local pharmacies in the area to try to track down what they have filled, especially if they're a stroke patient and they're trying to figure out if they're on a anticoagulant for the physician. When they come from a nursing home, or if they're an inmate, they also come with the MAR. The MARs will show when they have been admitted to the facility. A lot of times they will actually show if they've taken the medication for that day or not. So I try to make sure that I put that in my note. The nursing homes will also put like start and stop dates on stuff, so I really try to flag that whenever I am putting it into the in the electronic medical record. If for some reason the patient's bottles come in and they still have medications in them and I can visibly see that they are not taking it correctly, I will ask the patient if they do take their medications on a daily basis. Sometimes whenever they talk to me, you can get the notion that they do not take their medications on a daily, even though they say they do. So I will put in the comment section on my on the updated home medication list. I'll put in the comments that patients stated they do not take their medications as prescribed. For example, if they were to take it 3 times a day and it was prescribed 4 times a day, I would let them know. That way they know if the refills don't add up to how they were supposed to be taken monthly. In the updated medication list, I will also put like the quantity that they take, the route they take it, the time of day they take it, and then how I gathered that information. You want to go to the next slide? And go ahead to the next one too. Next slide. And this is what it looks like whenever I am finally got all my information gathered and I'm updating for the physician before they reconcile their medications. In the column where it says patient, I can also put how I gathered that information. If it was from the patient directly, I can put, if it was from a family member, I can put it from a outside resource such as the MAR or the pharmacy if I had to call and contact them. I can put that I've talked to the physician directly. If they have samples that they received from a doctor's office, I will call and put that in, and then in the over-the-counter comment section there, I will put patient receives samples directly from the doctor's office. If the patient's taking an over-the-counter medication and they do not know the milligrams, such as their vitamin B12, I will also put in just the medication's name, but off to the side where it says over-the-counter, I will put patient does not know the correct milligrams of their medication. If the patient's still taking the medication, but they're saying they're not taking it exactly as prescribed, I will change that to still taking, not as prescribed, and then go into detail of how they are taking it. Next slide. Once I finish the updated medication list, I will go and write a progress note. In my progress note, I will state if there's more information that needs to be updated, whether it's with the actual physician or if the pharmacist actually has to talk to them. I will say how I got my information, if it was verbally by the patient, if it was at bedside, if it was over the phone with a family member, or with the pharmacist at the pharmacy. Once I complete the whole list, I will go in and I will state what I have removed, what I've updated, and what I had added to the MedRec, and that way the physician knows if they had seen that they were on the amlodipine 10 milligrams, but prior to that they saw 5 milligrams, I would put DC'd on the month before and then added the 10 milligrams. Also, I would put in the note there too that if they had recently upped the medication's milligrams, I would put recently updated by physician on the date that they had updated it. If patient says that they are taking something and I cannot find any background on it at all, if there's no history of it at the pharmacy, they don't have the bottle on them, but they swear they take it, I will also put this in the note, but I do not put it on the MedRec history. That way we have more chance to interview them a little bit further and figure out, or have a chance to have one of their family members actually bring in the bottle so we can confirm that. Obviously, we don't want to start anything that we're not for sure on. If there's anything outstanding, I do put it in this note, but I also will let the pharmacy know verbally that they need to follow up with certain items. And then I also send this to the admitting physician, and the pharmacy is able to pull this, and it's into their permanent record in our EMR. So anybody's able to look at it, such as the nurse if they have any questions, or anybody else that has any care for this patient while they're here. And after I do one patient, I make sure that I only do one patient at a time to prevent errors or anything like that. Once I'm done with that patient, I will securely either tiger text the physician, or a lot of the times they are present actually in the ED, so I'll let them know that I am done, and then they will be able to reconcile their medications for that patient. After I'm done with that patient, I usually have quite a list of admissions, so I go on to the next patient and do the process all over again. If I have anything that I need to go back and update on the patient, I'm able to go into the progress note and flag it as an update, and I will verbally let any of the physicians, pharmacists, nurses know that I had updated anything, as if I was waiting for the patient's family member to call back or anything like that. At the end of the day, I turn in a list of all of the patients that I was able to reconcile for that day. That way, we post it in the pharmacy, so the pharmacists that are doing the entries, they can know that I had actually met with that patient, and there's no question on if their MedRec was actually completed by me or if it was completed by the nurse in the ED. After I'm done with the day, I turn in all of my paperwork to the lead pharmacist. He checks everything, and then that's the daily process. Yes.
Next slide. Thank you, Katie.
You're welcome.
So as of September, as I mentioned, the program started in February. So through September 2019, we had reviewed 890 patients, interviewed them, and Katie had updated their med lists. And she spent an average of 55.7 minutes with each patient. So as you can imagine, that would be nearly impossible for that to be done by someone who is responsible for the other aspects of that patient's care. So we're very grateful that we had a technician that could devote that much time to each patient. Some patients were very quick, others took hours to clarify. Literally, she may have them in the morning and it was into the day before their lists were completed, and sometimes not even then, with questions still outstanding. And through that point, we had noted reductions in incomplete orders to pharmacy. We had noted reductions in the pharmacist's need to clarify orders, as well as the unintentional discrepancies that we had seen when this first started. So we definitely were able to tackle some of the things that we were concerned about. Next slide, please. This is just a graph showing the number of monthly incomplete orders to pharmacy. And as you can see, they did have a downtrend. It was a 7% reduction in incomplete orders to pharmacy from January till September. Now, if you feel that 7% doesn't sound like a lot, you may be thinking that, and I thought that too in a way. However, Katie or our technician would only be there a 40-hour period out of a possible 168 hours in a week. So if you multiply that by the other shifts that could be covered by a med history technician, you would see an even greater benefit. So just keeping that in mind, that coverage currently at our facility is not 24/7 for the technician. Next slide, please. We also noted, as I mentioned, a reduction in the pharmacist's interventions that were required to clarify a dose, a frequency, or just a generalized med history clarification. And this data came from Century 7, which is our clinical alerting and documentation system. It is a separate system. It's not something that is it is interfaced with our EMR, but it's not something that an intervention automatically generates when you make a correction in the EMR. So just keeping in mind that this is electronic documentation, but it's also manual in the sense that the pharmacist has to go into a separate system and intentionally document these interventions. So the data may or may not be fully reflective of all of the changes. However, there was definitely a reduction in the interventions documented from January till the September-October timeframe. In terms of the pharmacist's time required to spend clarification time on these orders. Next slide, please. And then here's the Leapfrog data. As mentioned, initially we were at 43% unintentional discrepancy rate. That was sometime in 2018, probably the fall of 2018. By January, we were at 37%, and right around the time that the Med History Tech program was implemented, we began to see a decline. And you can see by third quarter, we were down to only 6.7% unintentional discrepancy rate. And again, this is only with having a technician on, Monday through Friday, 10 to 6:30. So this doesn't cover evenings, weekends, things like that. So we were very proud of this impact and feel that this has definitely shown a benefit for our patients. Next slide, please. So just kind of some summary here. Basically, we did demonstrate, as mentioned, that the pharmacy technician in the ED has improved the accuracy of the med histories we obtained, reduced incomplete orders to pharmacy, and then decreased the time required by other disciplines to help clarify patients' home meds. One thing that really has stood out through all of this is really just getting our providers to wait until the medication list is updated before prescribing admission meds, and this would ensure that they are utilizing the most current history when they're prescribing those admission orders. Time constraints and maybe even frustration with the process, it is tempting to go ahead and prescribe meds that are on the list that might be outdated just to be able to prescribe them and move on. However, we have worked hard, and Katie's worked hard, and the ED nurses, and everyone has worked hard to try to make sure that the providers are waiting for those updated lists, and that way it is a safer process. And our feedback from our patients, nurses, our pharmacists, and our prescribers has been positive overall towards this whole initiative. Next slide, please. We have kind of already touched on this, that a technician impact would be greater if they were available 24/7. Next slide, please. Just some future applications, at least for our facility, just looking ahead. We would love to have the ability to reconcile or update med lists on all of our ED outpatients. Currently, as mentioned, we were focusing on patients who were entering by the ED but being admitted as an inpatient status. So we would love to have the resources to update histories on all of our ED outpatients, those even that are treated and discharged directly, and that way their lists will be accurate when they return again in the future. We also would love to be able to make improvements all across the process, not just at admission, but at every different transfer point, post-op, things like that, as well as the discharge process. There are always opportunities throughout that whole continuum. And then perhaps even utilizing a pharmacy tech in other areas that maybe don't currently have those resources, such as same-day services for patients that come in even for an outpatient surgery, or that might be admitted for an overnight or something like that, and getting those med lists updated with the depth that we're able to see Katie spend on these on ED patients and L&D as well. And just one more item, next slide. Again, just speaking for our facility, some EMR enhancements that could be considered might even further help optimize the whole process. One of the most important things, and this was actually recommended by one of our pharmacists, was that perhaps having patients' medications that they haven't taken in 6 months or greater listed on the medication list, but in an informational only status, not able to be reordered automatically by a prescriber. That way, that would prevent eye drops, for example, from a cataract surgery that was 3 years ago that are still lingering on the profile, preventing those from being ordered as an active admission med. Another example that comes to mind would be an anticoagulant. Perhaps a patient was stopped on that drug several months ago for bleeding, and then if that old list is pulled back up, there's a potential for that drug to be reordered in error or unawares. So just having those older meds listed as information. And then again, the inability perhaps for the prescriber to actually sign an order unless it's complete. And that would help cut down on those incomplete orders, missing doses, missing frequencies, and things like that. And then just an ability to kind of sort the home medication list so that you could very easily separate what the patient was on as home or outpatient from what was started on them as an inpatient. And that would help for clarity, would help with duplications at discharge, and it would make things a little bit more straightforward for our prescribers at discharge as well. So those are just some enhancements that would be on our wish list. That concludes our presentation, and we would be happy to take any questions if there's time. Thank you.
Thank you so much. You guys did a great job with your presentation. I'm so impressed by the improvements in your Leapfrog data. So I know it was a good win for the organization. Thank you for taking the time out of your day. If we have any questions, feel free to enter those in the question bar on your task, on your control panel. As a reminder, our next webinar is Wednesday, July 15th. We will have Claudia Newman discussing the implementation of our OB hemorrhage bundle at Carilion Clinic. We have one question for anyone wanting to hang on. Do you see a large number of patients coming in with good med lists or bringing in all of their meds? How does that look for you, Katie?
Yes, I do have a lot of patients that actually bring their bottles with them. Obviously, some of them are old bottles that I will just go through and put to the side. I will note that they have them with them, but it also gives me a chance to actually ask the patient if they are still taking it or not. Some of them come in with beautifully typed up med lists. I will look at the date. A lot of times they will put when it was last updated. The nice thing about a med list or the bottles is whenever I pull from the external history that I can compare what they have with them, either on their list or the bottle itself, to when it was actually last filled. If it doesn't add up and there's no updated list date on there, I'm able to ask the patient if they're alert enough, if they're still taking it or not. A lot of times the family members will just grab everything in the cabinet, whether it's separated or not, or the EMS providers will grab all their medications and bring them with them. I also tell the patients whenever they do bring their stuff and how wonderful it is that they do bring it and how it helps everybody. So if they are a returning patient, that they just continue to keep bringing it just because it makes it easier on everybody, especially if I'm not able to get to the patient, the nurses are able to just put the bottles out in front of them and enter the medications. It'll also let me see what the SIG says, because a lot of times patients will say, I take it once a day, but the bottle says twice a day. So I really prefer to see the actual bottles. So I just make sure that I let the patient know that it was greatly appreciated that they brought it, and if they happen to ever have to return, I just let them know, hey, will you continue to do this, whether it's a week away, a month away, or in the future, even to their doctor's offices, just so they can have the most updated list anywhere that they go.
Okay, thank you for that. I think all the listeners could agree that this is definitely something that could be stood up at other facilities across Virginia. So thank you again for sharing. It looks like we've come to the end of our allotted time. So thank you guys for your presentation. Thank everyone for joining. Please stay safe and healthy. And this concludes today's presentation. Bye-bye.
Thank you.
Thank you.